and so over to you.
Good news.
Okay.
We're good to go?
Yeah.
Excellent. Well, welcome to all those who are in the room as well as those who are being live streamed. Or we're being live streamed and you guys are being subject to the live stream. Welcome to the Health Connector Board of Director Annual Meeting. Our first item is election of the vice chair. Is that correct, Audrey?
That is correct. Do we need a vote to call the meeting to order, or does that just happen?
I think it
Okay, just declare a person.
Yes, we're declaring the meeting in order and we're going for the election of the vice chair. And does she give an election speech?
I have an hour and a half.
Okay, so are you going to take us through the vote?
I think someone needs to make a motion.
Move that Nancy
Okay.
Turnbull serve as the vice chair.
Second.
Okay, so now the motion on the floor is to vote for Nancy Turnbull to serve as vice chair of the board for 2026 calendar year. So should we start with Dimitri?
Yes.
Nancy,
Robin?
Robin?
Yes,
Matthew?
Yes.
Rebecca?
Yes.
Audrey, do you vote?
I do not vote.
Okay, and Nancy, you're gonna vote for
I'm going to
yourself?
abstain.
Okay, yes.
Yes.
Michael?
Yes. Yes.
Yes. Very good, and yes for myself, so amazing. Do we have any board members online
No, I think you're all here.
out here? Very good, it is unanimous, like in North Korea, so you elected.
Our
vice
dear
chair of
leader.
the Board 2026.
So I have the same range of power and control.
You are wearing red.
I am.
And we will, do we need a motion to adjourn the annual meeting?
Yeah,
Second,
Second.
and then I guess we're not online, so we can just raise our hands for
Yes.
those who vote yes. Those who vote no, motion carries, we adjourn the annual meeting. And we move into our regular Health Connector Board of Director meeting. And our first step of that would be approval of the minutes. I'm assuming people had either a chance to look at it or they're so relaxed that they don't mind what's in it. So do I have a motion to approve the minutes? Second,
second.
and hands for those who approve. The motion carries, the minutes are approved.
Secretary, we haven't amended the minutes in a number of months, just how good they are, how thorough they are, so just if I could.
That is all Nuri in blue.
Excellent, thank you. It is just like about creative. Now we each have to go around and say how good the minutes were. Okay.
You're doing an excellent job, Mrs. Stone.
Must be that health policy committee meeting that got you ready for it.
Yesterday got me ready. I had not been through an 8-hour lecture day since medical school, so that was a good reminder, good flashback. And so now I just wanted to also make both the group aware and people online that I will have to leave early due to circumstances beyond my control at around 10:10, and newly reconfirmed vice chair will be taking over for me. And so now we will move over to the executive director.
Thank you, Secretary. Good morning, everyone. It is so great to see everybody in person for our annual strategic planning meeting. We really appreciate the effort for all of you to be here, and we know our conversation today will be even better with us being together in the room. Before we get into our long-term planning, which will really be the focus of our agenda, I do want to just take a moment to situate us with where we are at this moment at the Health Connector and in Affordable Care Act history. Open enrollment, of course, began on November 1st, and we're nearly 2 weeks in. Thus far, operationally and systemically, things have worked well. Our team is superb. Their careful planning and foresight were second to none as we prepared for this particular open enrollment. But it is the case that this is the most complex and challenging open enrollment likely in our history, with the impact of federal policy setbacks and losses of vital subsidies that have been in place to help people afford coverage starting to bear down on our members. It is still too early to see clear trends or member movement at this point, but we are seeing significant volume at our customer service center as current members receive information about next year and attempt to make heads or tails of what it means for their budgets, their ability to remain covered, and their access to healthcare services. We have been and will continue to be clear with members about how they are being impacted by federal changes, and that these changes are not the result of Health Connector or Massachusetts policy decisions. We continue to try to help our members navigate these headwinds and to make sure they know we have their back. But the pain is real and it is hitting our people hard. The duress expressed by people reaching out to us in our call center, to our navigators, is profound. Individuals and families losing the help they depend on to afford to stay covered simply can't believe it. We have even had an uptick in self-harm threats by people reaching out to our call centers. I want to offer my gratitude to everyone on our team and in our call centers and in our enrollment assister community. These are sobering times, and we are in awe of the work they do on the front lines to respond to the stress felt by people in the crosshairs of these health coverage setbacks, which are sometimes also compounded by SNAP and LIHEAP uncertainty and other types of economic uncertainty. On the health coverage front, though, of course, one of the key changes hitting home is the continued congressional inaction to extend enhanced premium tax credits. We continue to closely monitor the dynamics in DC. We are not holding our breath. But if federal policy were to change and extend these subsidies into 2026, we stand ready to move mountains to change with it. We have a playbook and contingency plans in place. It would take about 2 weeks for us to rerun eligibility for everyone and communicate next steps, with many of the details based on timing. It appears after this week's end of the federal government shutdown that the next potential action in the Senate around the tax credits could happen in the first half of December. Again, our breath is not held. But if there were to be a resolution that delivers enhanced tax credits for 2026, we will use all of the open enrollment period through January 23rd and potentially beyond if necessary to give members the opportunity to adjust their coverage if needed. We will continue to keep you updated as the federal picture develops and any implications for our work in terms of member impact or on our operations. Turning to our agenda for our time together today, you'll hear from Andrew a brief update on our proposed regulatory change to take care of a technical cleanup to our program regulations and a request for your vote to close that update out. But we will spend most of our meeting today looking forward as part of our strategic plan discussion agenda item. This will include updates on our 2025 progress against our strategic plan and tee up for your discussion guidance the agency priorities we've identified for 2026. The Health Connector is now several years into the practice of anchoring our work in a strategic plan, and we continue to, especially at this volatile and challenging moment, feel aided by the framework it and this board provides as we weigh priorities and navigate complex directional decisions. Before I hand back to Secretary Mahania, I also would like to take a brief moment to welcome and introduce you to the Health Connector's first ever Chief Technology Officer, David Matreau, who started just about a month ago and has hit the ground running. He's sitting over here. I'm picking on him. He started about a month ago and has hit the ground running and getting his arms wrapped around the complexity of our work, challenges, and opportunities alike. David joins us with over 25 years of information management and technology experience, including 8 years of experience at the MBTA, most recently as its Deputy Chief Information Officer and formerly its Chief Information Security Officer, and 11 years with the State of Vermont's Agency of Commerce and Community Development. He's a transformational IT leader who brings a wealth of knowledge in cybersecurity and risk, enterprise technology, and data security and governance. Having him here for our strategic discussions today feels particularly right to me, as his planful and forward-thinking instincts are exactly what we're about at this moment when the stakes of getting our work right, which is in so many regards powered by technology, and the stakes are so high. We are thrilled he's on Team Connector and look forward to the board getting to know and work with him in the months and years ahead. So I look forward to our discussions today on our progress to become the most impactful and most unstoppable health connector imaginable at this critical juncture for our agency and the work we all care so deeply about. So thank you as always for your guidance and your support.
Thank you, Audrey.
Audrey, what kind of communication are we doing with the legislature? I'm sure are hearing from a a lot of constituents as well.
Yes, so actually Erin and Nuri do a lot of work with the legislature every year in advance of open enrollment. So we did a briefing last week for legislators and their staff to give them information, kind of the lay of the land, what we're expecting for this open enrollment, what people might be experiencing in terms of concerns and worries that they'll have as they're getting their notices and seeing these changes, what they can do to support them. So that's all in flight and happening, and we have really good relationships with legislative offices, so I think it will really be a two-way dialogue. We would imagine they're hearing a lot of the same kinds of concerns and worries that we are, so there's a pretty good line of communication open. There's sort of separate conversations and dialogue that there's more at the policy level that's happening as well, but just in terms of sort of constituent services and support, I feel like we have really good inroads there, and can keep you posted on what we're hearing, but I think it will amplify and be very similar to the themes we're hearing.
And then one of the things you mentioned was self-harm threats, which is just devastating to hear. What are we doing when we get those? And
Yeah.
also, I mean, it's terrible to be on the receiving end of
Yes.
that too, so.
Yep. So we have standard operating procedures in place when there are self-harm threats made. So those can include, obviously, the person can have the opportunity to talk with somebody else or to hand it over to a manager that might be more advanced with dealing with a call like that. Sometimes we're, if appropriate, we're in touch with local law enforcement for wellness checks, et cetera. So there's sort of an escalating cascade of standard operating procedures. We've also taken care with our call center this year to make sure that call center agents have the opportunity to take breaks after very difficult phone calls, so they're able to decompress and sort of recollect themselves. But that's top of mind for us because it is not easy to be in those conversations, both for our call center folks as well as navigators and enrollment assisters and others who are on the front lines. Thank you for the question.
Just to follow up on that, are there regular, I mean, given the trauma that everybody's experiencing, and to Nancy's point, also the folks who are handling the calls, are there regular debriefs so that in addition to the breaks, there's regular debriefs in terms of additional training and how to?
Yeah, there's definitely additional training that and we have a new call center vendor, and Trish, I would welcome if there's anything you would like to add, but we have a new call center vendor this year, but I know that's been top of mind in terms of all sorts of supports, debriefs. We're also getting regular updates on a daily basis from our call center in terms of what they're hearing. And then our folks are in touch with them to just be nimble and adaptive to what their call center agents need as they're kind of handling it through. Trish, is there anything you would add in terms of the
I think they're
supports?
giving increased breaks. They're making sure EAP is available. We're staffed such that we have enough so we can pull some people off to give them a break so they can, de-stress and other folks can cover. So AHS has indicated that they've checked all of the boxes that they have available for support for agents.
Right, thanks. Yeah, I just would imagine having a space at regular intervals to actually debrief the calls. Oh, I experienced this. And then also wondering, given that the people who are calling are probably experiencing trauma and in lots of different places of their lives, like in terms of referrals, like if somebody's calling about potentially losing SNAP benefits as well, like what kinds of referrals are happening?
That's a good question. Do you know, Trish, if there's specific handoffs?
I don't know. We can find out. And if we don't have those handoffs, we can make sure that we're doing warm transfers to the best of our ability. I assume other call centers are also high volume, so not sure how well we can do a warm transfer, but we can certainly take a look.
And EAP is a good avenue for that sort of handoff.
So we'll get back to you on additional support measures, but thank you for the question. It's very top of mind thought.
I mean, maybe when we get to the strategic discussion, I think one concern I'm sure we all have is the connector staff. And, this is a devastating time and in an organization that's mainly had, apart from the website.
Yeah.
10 years ago or so.
Yeah.
An upward trajectory. So
Yeah.
how can we keep people hopeful and energized and feeling supportive
Yeah.
as, work we all are a lot
Absolutely.
being unraveled to some extent.
Exactly. Yeah. Would love to talk about
Okay,
that in strategic conversation.
Trish, I guess the question I have is with regard to training of the agents. And since now it seems like we're going beyond just providing information about the connector, whether or not we're incorporating some form of trauma-informed training as far as the agents are concerned, and also perhaps some form of de-escalation, because it seems like we're introducing a whole new can of worm that historically we have not had to deal with. But under current circumstances, it's something that we have to figure out how to best manage. And being protective of the staff, because if someone calls you and say they're thinking of harming themselves, staff members may also be dealing with their own issues, and to have that pile on, we have to have a way of assisting them in managing that.
So a few responses to that. So there is a process for de-escalating anyone threatens self-harm or threatens harm to any connector staff, or just sort of in general with, you know, the status of the different, what they perceive as the different individuals contributing to their issues. So we do have a very detailed SOP in place for that. And that has been working well. We get notified, area police get notified if there needs to be a well check done. Managers and team leads at the contact center are included. So that all gets taken care of and we get notified. And obviously we let Audrey know if any of that, any of those notifications have come in. As far as de-escalation training, that is part of their training. And we did talk a few months ago. I know Audrey and Kimmery and Kimmery is running the contact center piece, have talked to the vendor about de-escalation training, about any sort of training that the staff needs for their well-being. So we did do refresher trainings on both of those. They are part of the standard training, but we did want to go back when we knew there were changes to OE and changes to the premiums, just to make sure that the agents were aware of how they can handle calls.
Eric?
Yes, I know the term EAP has been thrown around. For those who don't know, it's Employee Assistance Program. Employers offer that, and organizations offer that support. It's confidential behavioral health, mental health support that can be offered to employees. It's a great resource. It sounds like everybody's using. My question, Audrey, I know you mentioned it's too early to tell, but I'm curious if there's any signals as to whether we're seeing early on an increased number of people saying, forget it, I'm going uninsured. Or if they're saying, okay, I'm just gonna buy down to get something. Any indication yet?
I think we're seeing both, because we have some time between now and December 23rd, which is the date by which people need to pick a plan and make a payment to effectuate their January coverage. I think it is too early to see in our data. I would say from the call center data that I'm looking at daily, you can see people saying, there's no way I can afford this. It doesn't mean that they've yet disenrolled or that they've necessarily made a final decision, but there are people saying, I don't think I can do this. I will say I've also heard anecdotally people, and I haven't gotten to connect with you on this yet, Commissioner, people who are saying, I can't afford that. I'm gonna go Google around for something else. So I think we really need to be on guard around junk coverage. There's people who are feeling desperate, who feel like, of course I have healthcare needs I need to get taken care of, but I can't afford that. What am I gonna do now? That's gonna create a whole class of people who are particularly vulnerable to bad actors. So I think we need to be collectively on guard for that. One of the things our call center and other agents and others are doing are guiding people, particularly for folks losing connector care, looking at bronze plans, looking at narrower network options. Can they find their way to a lower cost option that is still comprehensive regulated coverage, of course. So I think it's still too early to see what people will do. And it might fall really differently among different types of folks, right? Like the plan type 1 people who are losing all their subsidy and are very low income. I think we're going to see those people I think that's a group that we're just going to see drop coverage.
Yep.
I think for the kind of more moderate income folks who might be losing connector care or losing some of that PTC, that might kind of split down the middle maybe in terms of some people saying, I'm going to forego coverage or go take my chances with something not approved by Commissioner Caljo, or buy down, that kind of thing. So that's something we're going to keep a really close eye on week by week as we get closer to December 23rd.
Thank you. And I would also add an answer to Nancy's first question about legislature approach. One thing that's been very helpful is the close connection between Audrey and Mike.
Yeah.
Levine, the undersecretary for Mass Health. I would say that we have not had a single meeting with any legislator. So we're talking about Medicaid where the connector hasn't come up. Where explain what's happening, how the numbers are different from what he's talking about. That's exactly good.
And
And
that's like-
yes, and following Nancy's example, I think that the whole, all the board members are aware that this has been a period that's been incredibly busy for the connector staff. Stressful with the changes to new vendors, but also with just handling the emotional, philosophical changes that are happening. So also wanted to express our gratitude to the connector staff for the incredible work that's been going into trying to make sure that our clients are as well served as possible. Secretary.
Just one comment, if I may. So as I'm thinking about those who find themselves priced out, newly priced out of subsidized coverage, of course, they have all the options that you suggested. Another option would be joining a spouse employee sponsored plan. And so just thinking about it from the GIC's perspective, our annual enrollment is in April for coverage starting on July 1st. And I can't imagine this like declining to renew coverage because you lose a subsidy. I
Right.
don't suspect is a qualifying event that
Yeah.
would give someone the opportunity to join,
Right.
but they may in like later on in the year for us or other employer sponsored coverage. So it might lead to some people biting a bullet
Okay.
for 6 months, dropping coverage, going to their employer sponsored plan.
Right.
Just a set of dynamics there around employer sponsored coverage that might be interesting to
Yeah.
track.
And we should explore special enrollment periods in conjunction with that, because one of the key themes here would be making sure people have coverage. And to the extent they are doing that shopping around or looking to join an alternative set of coverage, we should maybe consider also.
I think that's worthwhile.
So we-
Yeah, we've been thinking about flexibility around open enrollment or special enrollment periods just with respect to the connector. But I think that's a fair point. Places where employers or employer plans could be more flexible with allowing spouses or dependents to join coverage. I'm looking a little bit at Eric because he might be more familiar with those rules, but I think we could think, you don't think so?
I don't think that's gonna,
Yeah.
I mean, as a plan, I don't have that flexibility
Okay,
from
under
the federal
law.
government.
Okay,
Like the qualifying events are what they are. and I
Right.
can't imagine
okay.
I wonder,
Maybe it's-
federal regulators are gonna be particularly understanding.
yeah, I think it's worth exploring a little bit more and exploring whether there's any bucket that it would fit into.
Mhm.
Cost of coverage has changed.
Yeah,
Right.
material change.
Material change
Material
has
change.
some
Fits
flexibility.
into that.
Okay. We'll look into that.
And I think there's alignment across the stakeholders in terms of using all the tools that we have in our toolbook here in Massachusetts. So
Mhm.
let's follow up on
Okay.
that.
And can you remind me or walk me through again what the various grace periods are? For when people have to pay their premiums and what
Yes.
happens, and what you've heard, at the end of the day, coverage is a vehicle for people getting the care that they need.
Mhm.
And so what we've heard from providers about, particularly people that might be in the midst of an episode of care in varying ways,
Mhm.
about how you think through that part, that's probably a little bit beyond. The grace periods, I think, is actually quite in our purview, and I think thinking about how our carriers are gonna deal with that matters. The care part may be less so, but I think ultimately that's what we care about.
That's a great question. So a couple points of relevance on the timing. So December 23rd is the time by which people need to make a decision about their January coverage. We do have another month of open enrollment, so people can do things for February 1st, but that's a kind of a red letter date. There is a grace period for, and I'm gonna look at Andrew and Marissa, correct me here, but there is a grace period if you don't make a premium payment, right? And you can stay in coverage. Is it 90 days? It's complicated.
Subsidized.
Yes, if you're
The people
subsidized.
We're most worried about losing coverage, I think, are the unsubsidized people, they would not. So-
Because they will have just become unsubsidized, right?
So in January, after they haven't paid, we would let them know they were delinquent, and if they haven't come current by the end of January, they'd be terminated retroactively to December 31st.
And we have also some experience in the commercial market outside of the subsidized product lines where the carriers have generally aligned on flexibility. We wouldn't necessarily call it a grace period, but sort of understanding that there's a payment processing level of flexibility. Each of the plans has embraced that.
Mhm.
Historically, we last saw it really used vibrantly or as vibrantly as we've seen it during COVID.
Mhm.
And so I think that similar principle would extend now, and our plans have been very responsive to that.
The other piece I would note is for folks that are losing plan type 1, so the folks that are really the most vulnerable from an income perspective, they will be eligible for health safety net. So from a care perspective, they can continue to get much of the care that they're receiving today under connector care at community health centers and hospitals. So part of the communication endeavor with that population is to make sure people understand that they can still get care. It's not coverage, but that's an important feature
This
for
is-
that population.
Right, and this is probably not where we would go in a strategic planning, but this ends up being very complicated communication.
Right.
So you don't want to send a message,
Correct.
just go get your care without paying the coverage.
Correct.
Because that's not really
Exactly.
a
Right.
good solution.
That's been,
But you
yes,
want to make sure that people understand if they lose coverage,
right.
that doesn't mean they have to stop all
Stop
the care
going.
that they're getting.
Exactly. Right. Exactly. So we're working on that, and we've been working hand in glove with folks at EHS and Mass Health on a really refined communication strategy there to that effect. That has all sorts of other policy implications and questions in terms of the long-term fiscal health of the health safety net, but in terms of just one foot in front of the other for the purposes of people who are currently receiving care, currently in need of care, for that population, for that low-income population, we want to make sure that they don't just cease their
Exactly.
medications and their care.
Yeah.
Yeah, this becomes a care continuity conversation in a way that's distinct from a coverage continuity perspective, unfortunately, because the Health Connector was created to be a coverage.
Yeah,
Yeah, mission.
I agree with that.
Just ask one other follow-up question. So as the drop, and I definitely feel like I'm still catching up on all of this stuff, but as the sort of drop dead deadlines approach for folks, can you just share what are the increasing communications to that group of people?
Yes.
Like what are the modes and how much more communication are they receiving?
Yeah, people have been hearing from us very regularly in the March up to open enrollment. That's
Right.
continuing to happen now. We released a number of emails to our entire subsidized population this week, continuing to sort of add additional clarity to what is happening and why. As we get closer, so that will continue. That's happening through paper mail, that's happening through email, text, the rest. As we get closer to December 23rd, we start to intensify and accelerate how much communication we're doing, just so we're really grabbing people's attention. But we can also iterate, right, and refine. So based on what we're hearing, what are the points of confusion that we're hearing about in our call center? What are navigators hearing? We can adjust those really up to the minute before we issue those communications. So we're able to stay pretty nimble, but it gets pretty loud as we get closer to December 23rd. And we're gonna have our work cut out for us as we're both trying to support people who are feeling priced out, but also encouraging them to stay covered. And it's gonna be it will feel like a paradoxical message.
Right. And do you sort of analyze the messaging and what generates the most calls? And I don't know.
We
if you
do.
A/B testing.
We do,
Yeah.
yes, we do. So we watch like our call center, we're in very close touch in terms of like when we send a communication, what does it do for the call center and
Uh-huh.
understand all of that. We do A/B testing
Yeah.
and, this is an unfortunate policy experiment we're living through that none of us would have asked for, but I think there's a lot we'll learn about how we communicate with people and what breaks through and how it shakes out in terms of member behavior.
Thank you.
Thank you for that. And we'll move on to finally the emergency amendments to Health Connector program regulations.
Good morning, members of the Health Connector Board. I'm Dregan, the General Counsel, and I'm here to talk about our emergency amendments to the Connector program regulations. Start with a little background. So in September, we came to this board to ask for emergency amendments to our connector program regulations. And those amendments were to adjust eligibility for connector care plan types 1 and 2, starting in 2026, and to align those eligibility thresholds with federal premium tax credit eligibility. This was in response to the loss of PTC eligibility for individuals who are under 100% of the federal poverty level starting in 2026. And that is as a result of the One Big Beautiful Bill Act, so-called, which effectively eliminated our connector care plan type 1. And so what this did was leave a gap for individuals whose incomes were exactly 100% federal poverty level. We estimate there are about 10 people in that category. So just to briefly describe what those regulation amendments did, we adjusted the threshold for connector care plan type 1 to change it from being not in excess of to less than 100% of the federal poverty level. And for connector care plan type 2, we changed that from more than to at least 100% of the federal poverty level. So our emergency regulation amendment process, the way that worked is, so the amendments became effective the same day that this board voted to approve them. And that day also kicked off a public comment process. The Health Connector held a public hearing on October 23rd, and that was the same date that was the deadline for written comments. We received no comments and no testimony. In order for the regulation process to be complete, the board must vote to finalize them following that public comment period. And the emergency process gives us 3 months to do that and make the regulation changes permanent. Because we did receive no comments, we are recommending finalizing the amendments without any further changes. And if approved, we would then file a notice of compliance with the Secretary of the Commonwealth. I'm happy to take any questions or the Secretary for a vote.
No questions, just thanks to the team. I think it illustrates that even the smallest change requires months-long process of work due to the regulatory standards that we're all subject to. And with envy, I would move adoption of the amendments.
Second.
Very good. All in favor?
Aye.
Excellent. The motion carries. You are good. Now, the next item on the agenda is a presentation on the 2024-2028 Health Connector Strategic Plan, which will be presented by Karen Tseng and Marissa Wolfman.
Before Karen and Marissa take us into the strategic plan, I just wanted to share a couple of very brief notes on this presentation. This is, I think, in many ways, it's my favorite discussion that we get to have with the board each year. I think the most important one. I think that's true every year. I think it's particularly true this year as we look at a very challenging environment in terms of our situational awareness of where we're at. We're looking at a very hostile federal policy environment, a pretty sobering state fiscal picture, continued really unsustainable, to use the word that Commissioner Caljo used yesterday at the cost trend hearings, an unsustainable healthcare cost environment in the commercial market in which we're situated. And so to me, as an executive director of an organization really kind of at the intersection of a lot of these forces, to me, that just underscores how incumbent it is upon us to be shoring up everything we absolutely can in terms of what we have control over. And so, to me, that means us making sure that our operations as an organization are absolutely rock solid, that we are thinking in new ways about how we can bring in every single eligible person into coverage, as many as is humanly possible under current law, and with available resources. That as an organization, we're capable of revisiting prior decisions or approaches that might not make sense anymore in the future, that we're ruthlessly careful about the way we use precious public resources, that we're thinking about how we set up an organization that can withstand the stressors we're likely to face in the coming years. That means being an organization that is prepared to conduct scenario planning, contingency exercises, a willingness to make hard choices, to be thinking about novel pathways to expand our reach in financially sustainable ways. And really just that we're clear-eyed as an organization about how much pressure there is on our performance as an agency. But the good news, if I can say that, is this kind of thinking is exactly what we started doing at the Health Connector about 2 years ago. So in a lot of ways, I feel like we're ahead of the game in terms of where we would otherwise start to be at a moment like this. We've started to push ourselves to think about customer service and public excellence and operational solidity in new ways in terms of delivering public excellence. And a commitment to not just being impressive in our public facing kind of policy and program work, but in the operational shadows where the way we pick up phones and answer people's questions, the way we think about our budget, our internal standard operating procedures, where all of that happens, which from my perspective is really where we show our public what we think of them. That's where it really shows up. And I want to make sure, and the team will talk a little bit about this, while we're really about looking forward in this conversation, the progress we've made as we've started to think more like this as an organization is real. We're showing up in different ways for our members. You can see that in our performance at our call center, our new call center vendor. Last October, our service levels were 79.98%. This October, they were 98.16%. We're saving $6 million for the public annually because of the transition that we undertook on our call center front. We are being tougher on vendors that do work on behalf of the Health Connector. Our member satisfaction is higher than it's ever been at 82% and climbing year over year. Looking at the hostile federal environment, I see us leading instead of just white knuckling through it and fighting. We're fighting. I see us becoming a more data-driven organization, so we're sure we're making clear-eyed decisions. I see us doubling down on good business governance in terms of our standard operating procedures and business governance generally, and starting to work on functional road mapping. So again, as we look really from the perspective of wanting to be as clear-eyed as absolutely possible, as we look at a very challenging policy, fiscal, and market environment, the commitment we feel at the Connector from a leadership and a staff perspective about how we best position ourselves to weather the storms we know are happening right now outside of our door and are coming. We've never been more committed to it. So I really want to thank this board because I know that you've had our back as we've really pivoted over the last few years to shore up our foundations as an organization, which I think is going to set us up for the most success possible as we encounter this increasingly volatile environment. So I'm thankful to my team for taking that on and for Karen and Marissa for leading us through today's discussion.
So thank you to everyone. Building off of our executive director's remarks, our goals for today's conversation are to first recap the progress that we've made in 2025, and again, to draw the connection between that body of work to preparedness for the challenges we see ahead for 2026. Second, to affirm as a body our organizational priorities going into 2026. And third, and most importantly, to hold space and preserve the majority of our time for input and guidance from each of you on positioning our agency for the future, especially in light of those continued headwinds. So a reminder that we began development of our current 5-year strategic plan in 2023. We incorporated input from this board, our staff, a wide range of stakeholders. This visual shows our 4 interrelated focus areas. At the top in teal, improving and modernizing the applicant and enrollee experience. To the right in maroon, maintaining and strengthening organizational structure and system reliability. Down to the green, improving equitable access to affordable health insurance coverage. And delivering high-value coverage options to residents of Massachusetts. Each of these are informed by our values: person-centeredness, equity, value, and reliability. As we look ahead to 2026, this slide highlights the interrelation of progress and preparedness. That is a touchstone for our discussions about 2026 and beyond. Over the next few slides, as we recap investments that we've made in 2025, let's consider how those investments position us from a stronger foundation going into 2026. And that kind of forward-thinking preparedness that Audrey described needs to be a hallmark of all business organizations, whether during tailwinds or headwinds. So this slide shows how in 2025, we continue to dig deeply into our administrative burdens work, as well as our integration and coordination work with fellow agencies. You'll recall the Health Connector held ourselves to a sludge audit 2 years ago to defrictionalize, streamline, and eliminate unnecessary administrative burdens for our members at every step of the eligibility enrollment process. Similarly, in the second half of this slide, you see our continued partnership with Mass Health and the Department of Transitional Assistance on true one-stop, one-door eligibility and enrollment. Part of what this means for 2026, beyond the specific deliverables highlighted in this slide, is that as an organization, we expect to have more and better muscle memory and cycles of change agency to tap into as we take on those new administrative burdens that the federal government is imposing on our members beginning in 2027. Similarly, as the federal government operates to make eligibility for public benefits more complex, our interagency work only increases in importance to position the state as nimbly as possible in terms of our statewide ability to coordinate seamlessly on eligibility for residents who may frankly be ping-ponging between programs. We're also poised to consider operational efficiencies under that kind of a shared system, reducing duplicative efforts and costs across these 3 agencies. This slide shows, as our executive director and as our deputy executive director touched on earlier in our conversation, how we're leaning into holding our vendors to account. In 2025, notable is our transition to our improved contact center operations, improving that service level performance by double digits from 2024 to 2025. As each of you has also heard during meetings over the course of this year, we are reaching for the next operational rung in our core enrollment and premium billing functions as we transition from Softeon to Maximus in 2026. We know these investments are important in their own right, and they're equally essential from a forward-thinking view of ensuring our core business functions are starting from a place of greater stability and strength. That stability and defrictionalization, those core business functions running as smoothly and seamlessly as possible, helps buy us that mental and physical bandwidth we need to handle the new challenges coming our way.
Maximizing impact and efficiency isn't limited to our systems and operations. It applies to our staff as well. We've put in a lot of energy to minimize friction for staff through initiatives like our project to thoroughly document standard operating procedures across the agency in a coordinated and cross-functional way. We also made significant changes in our data infrastructure this year. We recognize the importance of bringing data to bear to evaluate and to monitor our work. Our expanded capacity in this space has been essential in our analysis of proposed federal rules this past year, as well as the impact of expiring premium tax credits, allowing us to look at differences in impacts among a variety of subpopulations. Data infrastructure was one aspect of our 2025 work to respond nimbly alongside our marketplace peers to articulate the impact of proposed federal changes on our members and on our market, influencing the policymaking process with our data and our expertise. We've continued that dialogue at both the state and national level in collaboration with other stakeholders around the impact of enhanced premium tax credits. We also strengthened our work this year on network adequacy in close collaboration with the Division of Insurance. So thank you, Commissioner Caljo and team, for your partnership on that. And while we continue to push forward on small business coverage, slowly but steadily gaining market share, we know there's still work to do on access, affordability, and to reduce administrative burdens.
Okay, so just a couple slides to help frame 2026 and our board discussion. So here in the left-hand column, you can see our agency-wide priorities for this year. As a reminder, identifying those key priorities at the start of each year helps cascade all of the supporting work streams and work tracks and our staff's day-to-day activities with as much focus and deliberate progress as possible in support of our strategic plan. In our mid-year strategic milestones report shared with each of you in July, we signal that the first two of these priorities in 2025 are, of course, multi-year initiatives that will carry over into 2026. That is the transition to our new enrollment and premium billing vendor and our continued policy leadership on coverage and affordability. In the third row, with the successful implementation of our agency's new contact center vendor in April of this year, going into 2026, we are lifting up into our top three, our intensifying focus on strengthening organizational infrastructure that is central to positioning the Health Connector for the future. This slide is a nice visual that maps each of those three agency-wide priorities to the four focus areas in our strategic plan. From how EPB implementation directly helps us improve and modernize the applicant and enrollee experience, all the way to how strengthening your organizational infrastructure directly ties to maintaining system reliability. So this is the last substantive slide before we turn to board discussion. Our goal here was to tie each of these 2026 priorities to the theme that you've heard throughout this presentation around organizational preparedness. We touched on earlier about our core enrollment and premium billing functions needing to be as tight, seamless, and stable as possible to ensure that we have that continued bandwidth, mental and physical, to turn to incoming challenges. Similarly, being in the practice of continually evaluating our programs and offerings and recognizing that needs are changing helps us and trains our organization to be more agile in accounting for, again, tailwinds or headwinds and seeking to maximize our impact. And here in the third row, you see examples of some of the type of work that we consider encompassed within deepening and strengthening organizational infrastructure and how that ties to preparedness for the future. With that framing, we'll leave this slide in the background as board members consider these questions and others as we look ahead to 2026.
Yeah, so yeah. Mike, you want to kick us off?
I think we were just gonna start with just saying a bunch of stuff. So asking a bunch of questions. So one thing that I liked, it was on the previous slide under the budget row, but in general is the idea of scenario planning. I think that goes beyond just thinking about our budget nimbleness, so obviously that matters. And so I think the question you posed a second ago of the challenges we face, several of the big ones, Avi mentioned the overall policy environment and the fiscal. I think the biggest challenge is healthcare costs are going up, and that's a huge problem. And it's a particular problem in the federal policy environment and sort of the economic situation just across the country and in the state. I think apart from those things, which I believe are a bit more obvious, the one that I worry about that hasn't gotten as much attention is sort of carrier participation in a bunch of ways. I think we're fundamentally structured in a way that that needs sort of competition amongst carriers, strong carrier participation. We're very contingent. I know we have a lot of engagement with our carriers, but I think it's important to think through what would happen in different scenarios with different carrier behavior, particularly some of the ones that have a lot of our members and some of the ones that are lower cost on the exchange. Because if we were happening to face, if those carriers face particularly strong headwinds, which they might, and if that manifests itself in what we see, we'd really have to think about how we would react to that, because that I think would be a big change for the world we live
Ella, I don't want to put you on the spot, but I see you nodding emphatically to that.
Well, you know, with the cuts happening in Washington in federal payments, not just for our connected care population, but for the Medicaid population, I think it'll directly impact the carriers that support our big connected care populations. And all the health plans are teetering right now. So it seems like we should be scenario testing or doing some what ifs on the health plans in our market and, you know, what ifs.
We don't wanna speak the what ifs part.
So let me, I'd like to dig in just a little bit and in my mind, I think we have known knowns and known unknowns, as somebody once said. And I think exploring the known unknowns will be really important in terms of protecting members in the future. One of the items that I think it merits us digging deeper into is how we can better support members moving forward relative to what will be the constant churn of potential provider carrier disruption in the market. We have some good news today in the fact that Blue Cross and UMass have reached an agreement on their contract that was outstanding. But I think it's not going to be surprising to anyone in this room that we're now going to be in a constant cycle of potential disruptions. For the members that are impacted, I think we need to do a better job of requiring communications prior to open enrollment on those issues. Maybe even advancing policy solutions that require earlier notification to the state around July, perhaps, from both hospitals and providers and health plans around that topic. To the market-wide issues, I think that we can do some planning. I also think that there's some level that is so seismic in its impact that we could go down a road that doesn't have answers. And so I would echo, seeing it firsthand, I would echo the concerns about the financial status of the vast majority of the health plans and the connector. Those are real, not imagined problems. They are month to month in some cases. But we also have tools at the Division of Insurance that gives us the ability to look into information and help protect against contingencies that might develop. I think we'll want to continue to stay close to the connector on that. That work is highly confidential and should be highly confidential. But what we can take back to the scenario planning exercise is the trends that we're seeing in the market and some of the ways that we can better protect members moving forward. I also think we have to have a very honest conversation about the role that payers have moving forward relative to subsidized programs. And the fact that some carriers participate in those programs and some carriers don't participate in those programs. And I think that there's a public spiritedness there that is important to reflect upon. We have a unique market. We have a very strong preponderance of not-for-profit health plans that I think benefits this market. That may not be the case in the future. And I do think that we have an obligation to try to do everything we can to help continue to support that structure and that approach with an eye towards the member. So that's sort of a broad brush reaction to the conversation. But I also don't want to go so far down the road of too much detail that we either shouldn't be predicting or wouldn't be beneficial to more scenario planning for the efforts that we need to do. I think we kind of know how we would love to protect the member in the future. It's making sure that they know about their provider networks, where they can get their care, and how much is it gonna cost. Increasingly, we have less control over all of those things. Because of the federal uncertainty / idiocy that's emerged, we have less control over the dollar side in terms of the amount that a consumer pays. On the provider network side, we have less and less control over that because increasingly we're going to see pressures on the market that may pull apart or fray what has been historically a strong network structure in Massachusetts. Those two things aren't the only issues, but they're major, major issues for us to deal with. On top of it, we have underlying cost pressures that are due and owing to pharmaceutical and medical costs growing at unsustainable levels. Yesterday, the Health Policy Commission delved into many of these topics. And I didn't hear any solutions other than to double down on our work together to try to solve them and making sure that we keep everybody covered. And I think that's the sort of major interim goal that we need to tackle. I know Audrey, you and Mike Levine have been working very closely, and our teams have been working very closely on that issue. I feel like that's sort of the blocking and tackling in this next time period. Some of the larger issues, we're going to have to also tackle because these issues are going to get worse, not better. The risk pooling issues that Bella and Michael talk about, I think are real. And I think the state has to contemplate how to react to those changes. They're not mythical changes. Risk pools matter. And the inputs matter in terms of what the costs are. So that's I don't think there'll be easy solutions. I'll stop there. That was depressing.
Can I just react very
Yeah.
briefly?
I want to react too. but,
Okay. I will just be very brief. So thank you. That was, I think, a really helpful kind of, maybe not even a spectrum, but sort of a continuum on a theme. Coming back to the idea of scenario planning, I'm in agreement. I think there's value in us trying to anticipate risks we see coming and directionally how they would impact the connector, even if we can't foretell, the specifics, this carrier, that carrier, this cause of going over the cliff or that. But I do think a directional understanding, coming back to the idea of sort of organizational preparedness, is key. I'm even thinking, Bella, back to some of the modeling we did a few years ago, and what if risk adjustment changes? Okay,
Right.
well, it would have this effect on
Something high
a
level.
carrier, something high level.
Yeah.
And that would have this cascading effect on connector care program budget spending,
Yeah.
because you'd lose the lowest cost carriers at in this kind of a space in the market. So I think us being prepared to kind of have on the shelf, if a certain set of directional factors started to take hold, what the types of planning and reaction work we would need to do would be. And I think that can be kind of big picture for sort of budget and marketplace positioning purposes. There's also mechanical steps the connector needs to be hyper nimble in terms of responding to. So to the commissioner's point, I can't think of the last open enrollment period we had where there wasn't a standoff between a major provider system and a carrier that was sort of leaving open this question as our members were getting ready to pick a plan. Well, what even is the network? That's not a place we were 5 or 10 years ago, but that's the norm now. So as an organization, we need to be ready to, at a minimum, make sure people, we have better supports in place for navigating people through those types of decisions, in addition to the big picture readiness for this way or that way for the market type of thing.
To the scenario planning, sorry, I interrupted. I agree, and I think going into that discussion, it would be good to have our underlying principles of what we would like the market to look like. That then we can also scenario plan around. Because it's one thing to have a variety of different items out there to model, but to what end? And so I think, you know, there have been, I think, really productive principles that founded the work that we've done historically in this area as a Commonwealth. And I think it would be good to revisit those as grounding principles for where we would like to end up again. And then in the middle, let's pick 4 or 5 sort of different scenarios to model out actuarially.
So our bread and butter work, to the extent that I understand that, there's things like seal of approval, affordability schedules, what we do with premium smoothing. And I think the question is, when some of the less desirable things happen, the question becomes, what are the pressure valves? And although it's tempting to think the pressure valves are largely, well, let's work all together at the state to try and solve the core problem, which I am completely supportive of. I think on a day-to-day basis, we have to figure out how would we react in terms of some of those things, and in particular, where are the regulatory flexibilities and where are there places where we might want more regulatory flexibility. Should something bad happen in the future, but we don't have it now, we would have to be playing catch up in a bunch of ways. So for example, I don't fully understand how we think through, and maybe it's Commissioner Paujo, network adequacy rules. And would we, you know, and if we had to choose between that and where we are in a de minimis AV space, kind of set of things, or how we dealt with the money and the premium smoothing. There's a lot of issues where we might have to adjust should there be a problem. And I'm not sure which of those margins of change we have legally available to us, and then which ones would work. And I think the problem is going to be that in the bad scenarios, one way or another, we're not going to be able to accomplish we're not going to be able to achieve everything we would ultimately want to achieve, right? So the question is, in a sort of bad situation, how do you make unfortunate trade-offs? And I see those as the main areas that are sort of our annual course of business things.
Let me switch off to a different topic.
Can I say
Oh, I'm
something?
sorry.
So I think the scenario planning is essential. It's also very reactive. Like, what would we do if certain things happen? And one of the things you said that the connector has been doing, Audrey, is fighting. So there's also, I think, a proactive, policy-oriented agenda that really needs to be part of our strategic planning. And our ability as an organization to do any of the innumerable things that would be on my policy agenda is very limited. But picking up on the commissioner's comments about figuring out what the principles are that should underlie our work, and what does that mean in terms of both what I would call minimizing the carnage, but also positioning ourselves and taking affirmative actions to get to a better place. So on mine would be, we've got to do something about provider prices as a Commonwealth, or we will all have networks with like one. I mean, we will all have inadequate networks. And so there are things that some of us have been talking about for decades that I think the consequence of not doing them is so stark right now that we either need to give up or we need to reactivate a more activist agenda. And I think the connector can play with all of our other state agency partners and things, you know, it's a critical role in that. But if we just, my view is, do scenario planning and figure out how we'll react if this provider is, you know, it's going to be very grim. I mean, it's going to be grim anyway for a while, but the only hope and future that I think any of us want comes from figuring out what do we need to do differently? What should we not be doing anymore? I mean, what do we need again to kind of activate the collective will of the Commonwealth to change so we're in a better place?
And I just thank you for that. I will just say in a lot of the national conversations with sort of what I call the ACA warriors,
Yes.
there's a feeling of defeat right now, but underneath that is also a group of people that are thinking about what does come next. And, in the long arc of health policy and coverage expansion, I think we all know it's often, 3 steps forward, 2 steps back. Sometimes maybe it's.
I was gonna say the
forward, 3
reverse
steps
at the
back,
moment.
depending on the moment, but I do think it is incumbent upon those of us who have the bandwidth and the support, and certainly Massachusetts is one of those states to be thinking proactively in that way. And I think for us as an organization, that means both us being as, again, operationally rock solid, controlling the things we can control, all of that, but also being ready with what's the plan when conditions change. And that's not just about federal policy and trying to influence and fight on the federal front, although that is a piece of it, but also at the state level.
It's the
So-
state level.
For sure.
We have much
Yeah.
more control.
Yeah, and one of the things that I want to just crystallize a little bit more that springs from Nancy's comments, which I agree with, is that the Commonwealth benefits when we have full networks of providers and when we have strong benefits for our patients at an affordable price. We have had a long run where we were able to kind of get by. Not perfect, but okay. That's broken and will not continue. And so we need to have a very frank and candid conversation about what's the governing principle for what we want to arrive at. If it's full networks and strong benefits, then things have to change on the input side that's leading to the struggle.
Yeah, Eric.
Yeah, I'll echo some of this and also try to synthesize it from my perspective, which is day to day, working with employers and employees on these issues. And I'll sort of think of it and articulate it in the context of the recent news that you gave us this morning about Blue Cross UMass. I think what we're gonna need to do for not just in government, but for the community is reflection on what we demand in terms of access. And this is something that I have to continue to talk to my clients about, that you need to perhaps imagine a world where your carrier that you like so much does not have UMass in the network. And you have to come to terms with some of that in order for perhaps the pendulum to adjust a little bit. Because if our expectation is always perfection, we're getting in the way of good. And if our expectation is we must have everything at all times, we must have every provider in our network, and we must have no deductibles, we must have everything, then we limit ourselves as to what we can do going forward. So I think there's a community education part of this that I'm taking on as a benefits broker, that we have to also get past. Had one epiphany this year that the decision makers that I often talk to will often have different priorities than the end users. And one thing that we've seen in the work of the connector, in work with ICROS, is that when you leave the decision to the end user, the individual person, whether it's a plan design decision, whether it's a provider network decision, being on their phone every time they need a service and making a different decision each time. When you leave it to the end user, they often make very different decisions than sometimes the decision makers. Those decision makers may be people around this table or people like us that would not accept something, but we're making those decisions on behalf of people that might look at it differently. And that applies to network strength, our broadness of network. It applies to consumerism. It applies to getting care remotely, all these things. So I think there's an educational part of this for the community that we would have to engage in to try to bend the curve a little bit.
Let's do Mike and then Bella.
In a very tactical way, though, Eric mentioned something that I was gonna ask later, so I'll say it now, which is ICRAs. So there's actually a lot of interest in having bigger roles for exchanges in varying ways. And I don't think there's like that's imminent, but in a world where we had to think through how we would deal. So ICRAs have to do with employer people being able to buy on exchanges, and it may be our exchange or something.
Maybe somebody could give just a.
Eric might
I
do
could
that,
do
but
that.
my
Yeah,
understanding is
explain what
essentially
they are
if
before we.
employers can give their employees money and then they can buy on an exchange, I think is
Give
the.
them pre-tax money and they go on a fancy website and depending on where they live, they'll see all the carriers in their area and all the plan designs, and they get to choose using their employer's money in part, what carrier, what plan design they want. It's and you can do this in an ACA compliant way. You can use pre-tax dollars for it. That's the challenge on the connector side is if you buy a plan through a public exchange, it's right now it's post-tax for the employee. And so all of us who are implementing ICRAs are saying, well, you can't send your people to the public exchange because federal law says it's going to be post-tax. So you got to go direct to the carriers outside the exchange. So that's sort of
Again,
But the
in
idea
some
is still-
scenarios, that is something that one would spend more time thinking about how we would
yeah.
enable us to be more flexible to help people in other policy environments, because I actually think, depending on what you take as literal or not, in varying ways about money going to people and what they do, which I won't speak to, but us being prepared to play a role actually matters, and it is outside of what we normally think about or discuss, but I think it is probably closer than I might have said it was 6 months ago.
It is, it's growing. About 3 to 5% of employers are already doing it.
Really?
Yep.
And it's picking up in certain other states too with marketplaces, so Colorado, DC, so we can certainly, we've been monitoring and thinking about that, and I think a more receptive way than maybe we even were a couple of years ago. As you noted, there are sort of policy and tax complications, and also can kind of mess around with people's subsidy eligibility if they're offered an ICRA contribution by their employer, so it's not straightforward, but
That's why it's perfect for a strategic planning meeting discussion.
It's exactly the kind of space where we need a point of view, if nothing else, and to think about whether there's actually opportunity there for us in different ways. So stay close to you on that, Eric.
Yeah, Becca.
You were gonna go though, didn't you have something?
Oh, I'm sorry, Bella
That's
and
okay.
Becca. That's okay.
Well, I was just, I think Eric's report for me and also what I heard at the hearing yesterday, we're gonna have to make some hard decisions. And, network decisions, also benefit decisions. I don't know if folks saw the MAP paper on mandated benefits, but it's, in this state, it adds a lot to our premiums.
17%.
That's right. That's a big number.
Hard to
So
hold.
I think these are hard decisions that I think not just connectors going to have to make, but all stakeholders.
Yeah, the mandates are, so the state
Yeah.
requires plans to cover certain things,
Yeah.
including mental health, but all
Mental
sorts of
health,
things.
But
Every year it adds a little bit more, and today it's now 70% of our
Yeah,
total
we've seen
premium.
this movie.
Yeah.
Yeah. Bella,
Okay.
you
That's it.
good? That's
good.
You good? Becca,
Yeah,
and then Matt.
well, I really appreciate what you said, Nancy, in terms of the connector taking a more sort of activist role. That feels really important and being grounded in our principles, and also just what you were saying, Eric, about that sometimes the enrollees or the users might have different. I feel like we should be listening to them about what they need and what their priorities are. And I don't know if the connector has a history of doing focus groups or that type of thing, but I'm just thinking that especially the enrollees of the subsidized care, obviously, we talked earlier about how many things are coming at them, attacks on immigrant communities, SNAP benefits, like all of it. And so listening to them about like having focus groups or whatever about like hearing what would their priorities be as funding changes? And also, with so much coming at folks, what are the communication, like best communication? It feels like communication is gonna be really, really important. And so having, I'm sure there have been conversations in the past, but like another like round of conversations about what would be most helpful to them in terms of communication, modes of communication. Are there other, like you were saying, like I don't know what the term you used is, but soft Passover, you know?
Yeah, warm handoffs.
For a certain time of year.
But just making sure we're listening to, yes, who are most impacted. I appreciate that. If I could just respond. Yes, starting 2 years ago, we started to take some steps towards doing like member town halls. We've done focus groups in the past on various sort of discrete topics. It's not necessarily a regular occurrence at the Connector. Looking at Marissa, if you want to jump in with kind of where we're at on that. I have asked our team to start not just doing town halls, where we're going and asking members frankly to tell us whatever they want to tell us, understanding how they experience their coverage, but also taking steps to set up a member advisory council, which is just good practice for government from my perspective, providing services. So we can come back to you with some more specifics there, but I don't know, Marissa, what you might add from a kind of focus group perspective. Like the member voice is definitely at the fore at the Connector. We do extensive surveying. I'm not sure, Marissa, what else you might add for member voice centering.
The focus groups are usually targeted on specific, like reacting to proposals, but the listening sessions that we've held, you know, over the course of the last year or so have been incredibly interesting. In a variety of locations, virtual, a mix of subsidy and non-subsidy people. And so that's been rich feedback.
Thank you.
Matt.
So two comments, one sort of to continue this discussion about I think of it as member engagement because my enrollees are members. I don't know if I think of them as customers, but it's interesting. This whole issue just came up in a conference I was at last week of public sector health plan sponsors. Most of us were city employee health plan leaders, but a number of others in the public sector. And this notion of sort of member education, and we need to help our members understand more about insurance, understand how their products work, understand how to, you know, in the most efficient way possible, access services that bring value to them and to the plan sponsor. And I don't know if there's ever a discussion of this type or that type where something like that doesn't come up. I think it's all worth doing. Like, let me just say that, like, it's worth doing. But I think we should be modest in our expectations about what it's going to produce at the end of the day, right? You could do nothing but member education for a year, and you will have marginally raised the capability of the average person to engage in healthcare choices and decisions that would align with what an economist would want them to do, right? So
A bad thing necessarily.
what's that?
This isn't a bad.
I think most people would say, why don't you just make it
Well,
easier?
so I have this tension a lot, and now, look, we're gonna have different opinions about this even around this table, and that's okay. I myself tend to lean, I have a little bit more caution about setting high expectations about our members behaving as purchasers in healthcare in the same way that they do for anything else, right? And so that sort of brings the responsibility back to those of us who lead agencies to make important decisions as stewards on behalf of our members, right? So anyway, there's more discussion, I'm sure, that we can have on that front, but I thought it might be helpful just to add that. the other point I wanted to make is just to agree with Nancy and really echo what you said around just core drivers and our role, your role, Audrey, as leader of the agency, to continue to press for big solutions, right, on all the core drivers. If we don't do something about provider prices, right, like and it's already here. Like that was one of the comments I made at yesterday's cost trends here. It's not coming, it's here, right? Like we're here now. So happy to hear about the Blue Cross UMass resolution today. As Sarah Iceland said herself yesterday, like this is not the end, this is the beginning, not even the beginning. This is going to continue. So then this is going to lead to big trade-offs, right, as we're talking about. I'd say the same on the prescription drug side. Mike noted prescription drugs. I hate to like always use the same example of GLP-1s, but I'll use it. We are now in a position where purchasers of insurance are making a decision, and I completely understand why. It's not an unfounded decision to not cover an evidence-based, highly effective drug to treat a chronic condition with high prevalence in this state. That's like, that should tell us something that we're in different waters now. And so, but I'm sympathetic, Audrey, because we're in similar roles, right? And you and we as a board struggle with these larger systemic issues over which we individually have limited control. Mike, Audrey, me, like we all have our lanes, but I think our collective voice to continue to hammer home where the real problems lie that really need to be fixed primarily by state policymakers. I think Nancy, you said that. On the pharma side, that's going to be really hard to do at the state level. So, you know, I don't think it needs to consume a whole lot of our bandwidth because we've got day jobs and we got to make the decisions that are in our control. But each of our voices together, just sort of hammering home on the things that we all see in our respective lanes, I think it's more critical today than it was yesterday, and it'll be more critical tomorrow.
Well, and I think in addition to that, putting forth solutions.
Yes.
And I love your framing of
Completely.
big solutions.
Yes.
Not just, I mean, I always look at Karen and think of the groundbreaking work that Karen and colleagues did at the AG, like 15 years ago,
Generation ago.
10 years ago.
Have the data.
We've had these data forever.
I
And I would add the equity lens to this too, both to the GLP-1.
So what does it mean though?
And to
I'm
the-
sorry.
so
What?
I don't mean to interrupt.
yeah, I want to get
Go
that.
ahead.
So let me offer a framing lens perhaps for the conversation in a tangible way. Because I think we've heard a lot of really good potential modeling ideas. And as we translate the foundational principles to what we want into some of the work, I think there are short-term interventions, I'll call them, and then macro policy solutions. I think they're both worth exploring in greater detail because we're going to need to do both, particularly as we're being invited into larger policy discussions. I think people will mix and match the two and confuse them. We'll have product levers, you know, as sort of a framing lens. I would include ICRAs, you know, in the middle of that. There are other product ideas that may even include benefit design and network design changes in terms of product, direct to consumer product offerings. Some exist now, some may be ones that we want to induce the change towards. But then there are going to need to be models around risk pools and the impact of the different modalities into the price that consumers pay. Central to that is the provider issues in terms of cost, pharmaceutical concerns as well. But I think it's both of those sort of micro and macro issues, and I don't mean to say micro in a disparaging way, but I think we need to advance both of those arguments because we're running out of we're about to jump off the dock into the lake. We don't have many of those micro solutions left anymore.
I think it is easy to coalesce around the basic premise that if the state could do a better job in varying ways of managing the underlying pressures we face, we would have a much easier job accomplishing our mission. And anything we can do to help voices in those spaces work is probably a good thing. But I take micro sort of solutions actually is the positive, like that's really what we have in front of us. So I think I'm not sure we could all get on the same page about exactly what the right macro solutions are, although that would be a fun meeting to have and we could come down and do that again in person. I would love to do that. But I think there's other strategic things that I ask myself, like what role does the small business exchange play? And how can we use it more or less helping to solve some of the problems? What flexibilities are there around there? Because I actually think the small business exchange is one of the really prominent things we've done that I'm always struck by how much noise I hear about small business coverage and how we don't have huge enrollments on our exchange, and like understanding why is actually really important, because I do think that could be generally important in this world. The other thing that I don't know how it fits into our thing, and it's been, I think, even before my time on the board, which is increasingly long, our interaction with the broker community ends up being really important in the way that we use the brokers or the brokers use us, or the way we engage with the brokers to help foster sort of meeting our underlying strategic goals and how we can make things easier just writ large is actually a resource that I'm just not sure I'll say for me, I'm not sure I understand how it really fits in terms of what we can do in really a micro sense when we face the pressures I think we're going to face. And some of that involves anything we can do to make things administratively less expensive or complex for people or burdensome for people, that is better. And I think that's transcends what we do, but to the extent there's anything we can do to simplify the underlying administrative burden, harmonizing the administration, removing requirements that aren't accomplishing what we want to accomplish, I think is unbelievably important, because the real, I think, challenge in many ways is there's a lot of money that we spend that's going to things that we actually like. So we can talk about the GLP-1s, but the one thing about the GLP-1s is the reason it's a hard topic is because by and large, they're good.
Yeah.
It's when we find things, they might be overpriced, we could have a separate debate about that, but they're things we want people to have access to, maybe even more people. Again, we could debate that and their costs. But I think there's other things, activities that are going on that probably don't add a lot of value in a whole range of ways. And you can see the complicated administrative burdens and regulatory things that we have to face. And again, some of that's, I think, useful. But the more we can simplify the way the system works from the point of view of providers and carriers and stuff, I think your point, Robin, was right on. Like, if we could simplify things and make it just work better, we could also probably take some of the costs out of the system. I don't think we're a big contributor to the complexity of the system, actually. In fact, I think some of the things we do, like standardizing benefits, is an amazingly good thing relative to what happens other places. But I think the extent to which we can find places where we can help the delivery system function better, I think that's better, because that's, I think, the core challenge.
I think that's right. I think that burden exists within the commercial market, insurance companies, as well as within hospitals and health systems. But I agree, as long as we don't delude ourselves into thinking it's going to solve the central cost issue, it's an important kind of, I almost see it as a statement of a first step towards the work that we need to do. And I certainly, at the Division of Insurance, look forward to advancing reforms to root out administrative waste in short order that I think will bear some fruit.
I'll be a contrarian on that one. Just for the sake of discussion, I think we could spend a tremendous amount of time and energy on administrative application and save very little money and be in exactly the point that we're at. So I am intrigued by the thought of, could we be doing something different and more substantial in the small business market? I actually have that on a list of things to talk about in terms of, are there things we're doing that we shouldn't be doing? Because we're spending time and effort and money on them. And notwithstanding our best efforts, you know, we still have a de minimis share of the small business market. So back to the, I think on one of the slides, we talked about the zero-based budgeting. You know, I think at the same time, we need to be looking very hard at, is everything we're doing valuable? And are there other things? Are there some things we shouldn't be doing in the service of doing some new ones as well? And I don't know about that. I mean, I think I think they're policy levers, as we've talked about before, that like Vermont has and DC has, that really could make that a much more powerful force in the market. But I think it would require legislative changes.
So regulatory things elsewhere.
Yeah.
I'll just respond very briefly on
You can
small.
respond to
So that's a great example of the kind of thing I think we do need to look with clear eyes at. I could go on ad nauseum about how every small business in Massachusetts should be shopping through the Health Connector. It is so self-evident to me why it is in their interest. But we are not growing very significantly there, despite efforts. And it takes resources for us that are not then devoted to other types of our work. We do have a team that is working on a growth plan, but I do think as part of our clear-eyed thinking as an organization, we do need to put some parameters around it. Like, how long would we give ourselves to see if this can double or triple and really have a meaningful market impact, particularly in a moment of finite resources. I mean, we're always in a moment of finite resources. They're more finite than ever. So my perspective is we should give that team a chance to try some new techniques and approaches, but not try forever and not be emotional about whether it continues to make sense for all time.
No,
so small group has been on my mind for about a year in terms of, you know, why are we doing this? Because we have a broker community that has been here for a gazillion years, and the processes are in place, and they bring the business direct to the insurance carriers, and it's hard to break into that. So exactly, like, maybe we could use these resources for something else. And I'm going to say the same thing, and I know it's controversial, about premium smoothing. I feel like we have subsidized our highest price providers. And so it's kind of this perverse incentive. And I totally understand why we're doing it. But now that we're at this point where we have to make these hard decisions, I'd like to bring that back to the table.
So I think that's a really useful discussion about the small business exchange. I will just say that in any decision one makes, one has to think through the core questions. How many people would lose coverage? How many premiums would go up, right? So I understand it's not very big, but it is also the case that we spend a lot of time on a lot of outreach to try and get every possible person we can get insured, which is fine. But there's also a diminishing return to that type of outreach. And so I think we would just have to make whatever that's why a strategic planning meeting is useful, right? There's just sort of I would say this simply. I do understand and I believe that we need to be guided by a broad set of principles, but I also think we need to be informed by what I would call a core program evaluation sense. Like, if we do this, what are we getting for it? What are we losing from it? And how that meets in with our principles. And I think in the small business exchange, if you told me, well, look, we could just get rid of it and they're all going to go to brokers and they're all going to be covered, right? Then great. But I was actually closer to you or Audrey, which is actually quite a good deal for a lot of people. And I'm not sure the alternative if we got rid of it was that all those people would find their way to coverage. And so it's not clear that if I wanted to get X thousands of people covered, I'm better off putting that money into individual outreach as opposed to promoting the small business exchange. It might be, I just think that's why the data assessment of what the actual numbers are matter.
Yeah, and I think that data needs to include within its scoping what's happening in the merge market overall, in the growth of the self-insured market as an alternative source for people, and why are they going there? And so we, you know, I think as we do this modeling or scenario planning, I think we have to acknowledge the market behaviors and the choice towards affordability as sort of a key concern. That's an and, not an or to what Michael and Bella are saying.
I usually don't go to my right, but I want to be sure that the people on my left. Yeah, Dimitri.
We touched a bit on the small business access, and I think it's a topic that has surfaced since I've been a member of this board, and Michael and I joined on the same day, and it's been a moment. I would say that there are businesses who are using that service, and we need to make sure that we don't take something away that those businesses would not be able to go somewhere and replace. We have been dealing for a long time with just dichotomy between the broker community and what we're offering directly. And I think part of what's, from my perspective, needs to be addressed is the evaluation of the communication that's taking place between ourselves and the small business community to allow those small business community members to become more aware of the services and the options that they have in terms of buying their policies directly from us versus the broker community or communicating to them how we can work together. I think to touch on one of the key points that's been made over and over is we have a set of principles, and we are here for a purpose, and that's to ensure that we are providing access to folks who are in need of coverage. And I think there's a policy component to this, and we can spend days going over the policy components. And there's also an operational component to it. And I think we have to also spend as much energy looking at the operational component to ensure that we're touching on those core principles, which was the reason for the foundation of this organization.
That might be good teeing up. We haven't really discussed the last bullet point. We've talked about principles, but not values. And then Karen, in your presentation, you put forward 4 values that you said have guided our work for person-centeredness, equity, value, and reliability. I took notes correctly. So those evidently are framing values for the connector at the moment. I wonder if we could sort of test whether those should continue as we move forward to guide difficult decisions and trade-offs we're going to make. Are those the right ones? Are there more that we want to be sure are included?
You're asking for framing value.
Yeah, framing values. I mean, I'm trying to
So I think.
say what values do we think should guide decisions?
I'll start with an easy one, but I think we should lead with is that the Commonwealth and its residents benefit from having insurance coverage, and the connector and our sister agencies should do everything they can to ensure that insurance coverage at a high level is available for everyone in the Commonwealth. The thoughts are a little simple, it's under that, but I think it's important to lay out that framing vision.
Yeah, but foundational value of stuff,
Yes.
not just for individuals, but for the Commonwealth as a state. Yeah, Mike.
I think the value in some ways that is implied, but I think might be better to be explicit, is that we are fundamentally explicitly about coverage, but I think the core value has to do with health. And so we're providing coverage for a reason. And so when we make decisions about things like seal of approval, it is really not about whether you get coverage or you don't get coverage. It's making sure that you get the maximal health for the coverage that you have. And I think that sort of equitable access to health, I don't know, or healthcare, whatever you want to say, is actually when I think through the decisions, I'm trying to think through how do I make sure that as many people in Massachusetts have access to the care that they need that's most impactful. And I'll speak for me, if I had to make trade-off access to healthcare services that are really crucial, for lack of a better word, life and well-being, then maybe like we could spend a lot of time thinking about different gradations of care. But having access to low-value care is not something that is particularly high on my list of values. Having access to important chronic disease care, for example, is actually very high on my list. Is because the value has to do with what I think is happening to health.
Yes,
Follow-up
please,
question.
yes.
Centering health, how might you or other members of the board think about, you know, the outcome, like what you get out of health coverage being health? How do you assign a value to financial security as also a product of health insurance?
So again, as an economist, you might imagine that comes up a lot. And like if you read Kate Baker's and the other work at Oregon, it turns out the financial security is really important. And as an aside, it also has a lot to do with mental health, the financial security piece. So I think that's a value. I would put more weight on the health part than I would on the financial security part, in part because I think there's other mechanisms besides health insurance to deal with people's financial security. But I do think it is certainly, in a world of insurance, a core thing you buy with insurance is some financial protection. So I think it's there, but health for me would be a level higher. And I might say I would value health probably a bit more than I might value other values like freedom, choice, and provider, which I do value.
And do you value health or access to care as a
I'm valuing,
proxy?
I view access to care as a mechanism to get to health. I feel it as a proxy. The problem I have with access to care, and I don't mean to rant on, I'll try not to, is a lot of times discussions of access to care end up being implemented in a way that create access to care that might not add a lot of health, because we're fundamentally trying to get something we think is access. And I think that we do need certain barriers to certain types of care just because of the fiscal things that we face. But some of those barriers can really be deleterious to health, so.
Yeah, as a public health person, I feel compelled to add that if we were at the margin making investments to improve health, we would not spend it on.
100% agree, 100% agree, by the
Yeah,
way. And the extent that we had any purview there, it's really worth discussing.
Robin and then Dimitri.
Just a thought about the day-to-day things that we do that you mentioned, Michael, and one of them is seal of approval. Is there a way to use that seal of approval to get to some of these things we're talking about health? So, for example, I think there are lots of things that maybe the carriers are doing that aren't very valuable at all, yet kind of the market almost makes them do it to be competitive with the United Healthcares of the world and do all these flashy things. But is there a way that we can get to those kinds of things? I don't recall what exactly is in the seal of approval right now, but I don't know what questions are asked. But if I'm remembering back, it's pretty, you're not really asking a whole lot of questions about what people do and can they show any data that shows value to any of those things? I don't know.
We try to do that on the chronic care stuff that we try to do in the seal of approval to make sure that, like, again, for me, making sure that people don't face financial barriers to access their chronic disease meds, at least the relatively cost-effective chronic disease meds, was very high up on the seal. And I think we do that now. And that was also part of our equity lens activity, because there were populations that were affected by more types of things, and that would be very high. in
But that
benefits.
does suggest another area for some strategy
Mhm.
thinking.
Yeah,
and
for example,
rethinking as a seal of
It's
approval.
like a
and
hinge
service
or
of
what are
it.
those sword hinge health things?
Yeah.
Do they really add value? I don't know. You know, so I'm just thinking about what those plans look like
Yeah,
and
great.
do we need all of those
Mhm.
things?
Dimitri and then Becca.
Yeah, I just want to go back to an earlier point that Michael made. I think when we talk about financial security, health plays a key role with regard to financial security. As someone who's run a community health center in the past, one other thing I've always observed is that people who are the working poor don't want to take time off from work. So if they're healthy, then they are more financially secure. So we have to keep that in mind. And I think the other thing that Mike touched on is chronic disease management, which plays a key factor. We touched on GLP-1s, as we know GLP-1s is becoming part of the treatment regimen for a lot of providers as it relates to diabetes and other cardiovascular issues. So again, as we look at the shopping carts and we look at putting the plans together, while a lot of carriers are looking to exclude that, we know from what the providers are saying that that's something that's very helpful to folks who are suffering from those chronic diseases, which will have an impact in terms of their financial security. Those are areas that we can look at and see how we can leverage that to improve what our offerings are.
Yes, please.
I just want to respond really briefly on the question of what we can do with seal of approval. It's a very powerful tool because it's us setting the standards for what this board and this body considers good enough coverage to sell. And so just really quickly on a couple things, Michael is correct that we use seal of approval to zero out access to services and drugs for managing chronic conditions disproportionately borne by communities of color. So that's a way we've used it to try to promote access to high value care. What we haven't done is use seal of approval, and I think we need to think about this, to reduce access to low value care. That's not a space we've gone before, so I'd want to think more about that. And then Dimitri, just to your point about low income folks, have busy, complex lives. It's very hard to access care. I'm going to go back to Bella for a second. Bella had done an analysis a few years ago for the Merged Market Advisory Council and looking at sort of the risk composition of the merged market and found our lowest income members don't touch the healthcare system a whole lot. Like we do all this work to get them into coverage, which is great and a testament to our work and values in Massachusetts. But a lot of those people don't end up availing themselves of care. So using our seal of approval, I think it was 2 years ago, we actually included in our seal of approval in our contracts with the carrier that we expect them to do work with their low income enrollees to get them to stop foregoing care, particularly around preventive services, which are free at the point of service to them. So I think we probably need to look back and see what evidence they can share back with us about the work they've done. But that's an example of the kind of thing with seal of approval. We have contracts with every major medical carrier in Massachusetts, and we can think creatively about how we use that.
I feel I need to tell Emily Bryce, who you may or may not remember. We did do a study with her and covered California to try and figure out how we might put low value care into the seal of approval. It's actually quite complicated.
I got it.
That's really interesting.
How much information do we collect from the carriers as it relates to NCQA or HEDIS that we can look at to ensure that they're hitting that target population with regard to not just the quantity of care, but the quality of care that they're providing?
Can you speak to that, Marissa?
So, of course, all the carriers have to be certified, so they get their NCQA certification. They also report select measures through CMS, through quality reporting that get generated into star-based scores, quality scores that CMS calculates. So we get a little bit of data from that as well. We also have our quality improvement strategies where carriers are reporting out on select measures and their performance and improvement plans to increase those measures over time. We do get those items through a number of different channels.
How are we using that information?
So The stars go on our shopping experience, so that is kind of baked in. In terms of the quality improvement, we have been, so we've got baseline data. We shared some of that back in September on, across carriers historically, they may have been looking at different things. We've standardized some of those so that we can more easily compare. So we're working through the reports that we just got this fall to compare against last year when we first standardized that, so that we can report back and say, where do we have gaps? Where do we need attention? And then how can we address that through the seal of approval going forward?
I just want to add though, those metrics are not specific to the connected care market, right? It's for the entire commercial market or the merge market. So it's not specific to connected care.
And in Medicare, at least, which I know better, the evidence that actually doing better on those things actually makes people healthier is really not nearly as positive as one would think in a conversation about you should do all these things, in part because of, I think, clinical documentation things, in part because who the patients are at the margin. So I think it's important. Someone said this, and I think it's exactly right. You said it in the context of the small business market, but I think it is true in all of these things. It's very tempting to want more communication, better quality measures, better reporting, all those things, all of which I would say I want. But in practice, some of those things tend to not produce the results that you think they would produce. And so the more we understand where those things are actually working for us and where they aren't, the better.
And they can have perverse incentives in some cases.
Yeah.
To disincentivize care, so.
Yeah, well, I appreciate the conversation about financial security and health, and definitely believe that they are inseparable, and appreciate your comments, Dimitri. And then just wanted to underline the value of equity, especially as there are the policies coming from the federal government trying to, immigrants, depending on how long you've been in this country, depending on your citizenship status, all of that, there's clearly an attack on equity right now. So that feels like it needs to be front and center in terms of a value that's guiding us.
Yeah, and I would make it a little bit more granular, which I think embedded in that, I think should be a value of protecting the most vulnerable people first. And I think that was, for many of us, was so discouraging and disheartening. People who were kicked off, because it was the most vulnerable, the lowest people. And I think that was also, for me, part of the GLP-1 decision, is we know that those drugs can disproportionately benefit the populations, disproportionately suffer from the chronic conditions that those drugs are effective for, and our vote deprive them of it. So, yeah.
What one, I know we're running.
Yeah, we're running
long
discussion.
And this applies to both the subsidized and the unsubsidized market. I think we should say out loud, if cost is a barrier to someone receiving care, that's to be avoided. Or in both the subsidized and unsubsidized market, we should do everything we can to make sure that consumers do not self-ration their pursuit of care or are unable to afford insurance. I think it's important to make sure that we shine a light on that with attention to the subsidized population, but certainly has startlingly important considerations for the larger market as well.
We kind of embedded in that was the value I was tinkering with, is we should be brave and fearless truth tellers.
Yes.
I mean, I think we're kind of uniquely positioned to be able to do that.
Yeah. Thank you.
I don't know if that's
appreciate
a
that.
value, but
Yeah, I appreciate that.
I can see it on a banner.
I would just, if I can just respond to that, I think we're well positioned to do that because of who this team is and what motivates us every day. I will say, some of my team knows, I debated about whether to share publicly at the cost trend hearings yesterday and today to you all about the uptick in self-harm threats. But I felt a responsibility to tell the truth about it. Because I think part of the role we play is being in the center of a feedback loop between public policy and real human life experience.
Right.
And we're at the beginning of a period where what we have to say out loud is likely going to be hard. And I think it will express a certain degree of moral injury for a lot of us who have been engaged in this work. But I think it's important and it's really our only hope of clawing back to something where we have a public policy that is responsive to the humanity of the people we're here. So
Yes, I completely agree. And so thank you for making that decision, which I think we would all affirm was the right one, and we have to. Right, we're almost at time. Any
So
other comment? Yeah,
that you
Matt.
took good notes on the 4. I only had 3.
I always take good-
Reliability, equity, person-centeredness, and what was the 4th?
Just add affordability.
Centeredness, equity, value, and
Value, okay.
Reliability and principle.
Yeah, Dimitri, you can have the final word.
So much
Yeah.
embedded in value, yeah.
I wanted to take a moment and just commend the staff on the work that has been taking place as it relates to the strategic plan, as it relates to vendor management. And I'm looking forward to seeing more of it. And I'm looking forward to us becoming more data-driven. And part of that is taking ownership of our data to a certain extent, taking ownership of the vendors in terms of how they use our data and the level of control that we have. So hopefully, next time we get together and discuss our strategic plan, I would like to see the horizontal weaving of technology as it relates to our strategies and as it relates to our key pillars as we look at what we look to accomplish within the upcoming year.
I can just say,
Yeah.
just one thing very briefly, just to piggyback on that. We've done it a couple of times with the risk of repeating, but just, I know this, Audrey and I talk about this. This is an extraordinarily difficult time to do the jobs that we all do, all of us on the board, but so I think we should acknowledge just how hard that is. And to borrow, I think, a phrase, I won't attribute it, but it could be attributed to someone in this room, that being in public service at these moments, these kinds of moments, is the highest form of public service.
Yeah.
Just because it is so, you're on defense, it's unforgiving, it's relentless. You look around yourself sometimes and you want, like, what world am I in, right? The things that you really value most, you see being taken away. And that's the reason you got into the work that you do. And it is really, really hard. So I see all you and I see all your team who operate in that environment.
Thank you. Do you want the last word, or is there a better one than that?
I don't think there's a better one than that. I would just thank this board for their support and their guidance during the headwinds and tailwinds, and to my team. This has been an extraordinarily challenging year. The federal dynamics are unprecedented. And at the same time, our team has kept pressing forward. I want to give a shout out to Trish, who, to your point, Dimitri, the work we've done to extract so much more value and accountability for the work done in the Health Connectors name is profound. I've never seen anything like it in my entire public service career. And just the backing and support of this board and your enthusiasm for public excellence, including in the face of incredible challenges, is so appreciated. So I thank you, and this was a wonderful discussion.
Okay, so we need a
I'll move.
vote. Thank you.
Second.
Well,
Second.
did I even say what we're moving? All in favor of adjourning? Thank you. It's good to have these meetings in person,
Oh,
so we should at
definitely.
least like do it a couple of times here.
It's really
Yeah.
Zoom just isn't the same.
Thank you. Thank you.
No, I work in an office. We have an office. I go in that.
You can't have.
Don't get great.
You want to make sure we don't take.